Dr. Pieter Gaillard, who is in, where are you actually at the moment, Pieter?
I'm based in Leiden, the Netherlands.
Okay, lovely. Yeah. Now, we've been talking about this idea of giving inadvertent intravascular administration during vaccination, and you're I think it could be said, a pretty serious scientist who knows a bit about this. So what is the conclusion about aspiration that we could use to get people interested in this video? What do we need to get across? What's been done right? What's been done wrong?
Yeah, I think the main issue is that you don't want these particles, either the adenoviral or the micro or the mRNA particles, into your bloodstream. Mm-hmm. You should check for that. And you don't want to have them in the bloodstream. You want to have them in the muscle where you inject them. Yeah.
So the way this is being done at the moment, vaccinators are sticking the needle in, but they're not drawing back to make sure they're not in the blood system.
Yeah.
I mean, is that possible? Could that happen? If you put a needle into a deltoid muscle, could it end up in a vessel by mistake?
On very few occasions it can happen, and you can even just hit a blood vessel on the way in or out so that you get some bleeding. That happens a lot more often. And basically you don't want to have the particles hit the bloodstream or get deeper into the body. That's not where they are intended.
Yes. So I can understand that if the very tip of the needle ended up in a blood vessel, you could inject into the blood. But lots of people have asked me that if after the injection, they've had some blood on the injection site. Yeah. Does that mean they've damaged a blood vessel?
It has to, yeah. I don't think there can be any blood coming out without a punctured blood vessel. Doesn't mean the injection was straight into the vein, but there is an opening without it.
Right. So that would mean that the vaccine was in the tissues, but there was an opening in a vein, so some of the vaccine could leak into a vein.
Yeah, there could be. Yeah. We don't know how much or how damaging that is, but you cannot exclude that.
Mm-hmm. Yeah. So before we get into the detail, is there any practical application to this video? What advice would we like to give national agencies? What advice would we like to give individuals?
Yeah, I always start with the individual. I think I concluded a piece that I wrote, but you can always ask or demand basically that they check for the
absolutely
that they didn't hit the blood vessel, because it's your own arm, it's your own body, and nowadays it's easier to ask because there's more pressure to get vaccinated, so you can get another doctor to do it or another injector. In the earlier days it was more difficult because they would just simply say, then you're back in the queue whenever you're up again, and it could be a few months later. So I think now it's easier to ask. I know a few people who did. I certainly asked for it, and the doctors are trained to do it. Nurses are trained for it as well.
Mm-hmm. So what happened when you asked to get it? What happened?
Well, it was a GP and a friend who did it for me.
Oh, okay, right.
Okay. I could explain it first, and he obviously did that for me.
And you're still friends?
We're still friends.
Good. So really important point. If I'm going to get a vaccine, this is into my body. I am in control of this. And if I want aspiration, I should get vaccination. I should get vaccination with a vaccination. There's no ambiguity about that, I don't think.
Well, in practice there is, because there's quite some pressure put on the system. I don't know on who exactly, but at least it's not always welcomed if you ask.
It is. That's correct. Yeah. So we believe that this idea of inadvertent intravascular administration is a potential variable causing unwanted side effects. What sort of side effects could happen if you gave this vaccine into a vein instead of into a muscle, or potentially happen? What sort of interactions could there be in the body?
No, what I know, I personally developed these small lipid particles as a scientist, as a drug developer. And what I know is that it can induce, just by having a small amount in a higher concentration in the bloodstream, you can get an infusion reaction, which is also dubbed as the allergic reactions that people can get and now need to wait for 15 minutes. This got me actually looking at how do they inject it. That started my whole interest in this specific topic. Mm-hmm. But the first thing that can happen is an immune response and complement activation, your immune system responding to a particle, any particle.
So if complement is activated, that's going to cause an inflammatory reaction. potentially in any part of the body.
Yeah, it's a specific part of your immune system, and indeed you can get complement activators and mediators that cause cardiovascular changes, platelet activation, and that gets closer to, of course, the side effects that it means.
So it's possible that this form of injection technique, where we're not aspirating in most of Europe, the UK and the United States, could be contributing towards these side effects that we know about from the mRNA vaccines, particularly the heart inflammation and the side effects we know about from the adenovirus vector vaccines, which is the thrombosis, thrombocytopenia. That's a scientific possibility.
Well, I don't know if it goes that deep and long. It's always concentration dose dependent, and an individual, if they happen to be unlucky enough to get into that sequence of events.
Yes.
I cannot say it's directly causative, but if it doesn't get in the bloodstream, it wouldn't do anything.
So there could be other factors that we don't know about.
Yeah.
But preventing the vaccine getting into the bloodstream would take away one potential variable.
Yes, and the first one. So I think it's the easiest one to eliminate the chance. Checking.
So what is a lipid nanoparticle or lipid particle? What are these things?
So the mRNA in these vaccines needs to be protected and stabilized, because your body can otherwise eliminate it and break down too quick to get the effect of having the protein of the coronavirus expressed. So they are formulated in lipids, in body-owned lipids, and another lipid to capture the charged mRNA, and they are pegylated to keep them stable as a particle. Otherwise they stick together and form larger clumps. And that's a classic formulation for this kind of compounds. And these form in the mRNA particles in the order of, it's nanoparticles. It's really small ones, about 50 nanometer or smaller.
Yeah, absolutely tiny particles, yeah.
And a virus is about 100 nanometer, at least the adenovirus.
Yeah, about 100, yeah, that's right, yeah.
Double the size, but the body just responds to that kind of size particles, because it could be a virus or another particle that enters the body. And we've evolved in our immune system to respond to intruder.
Right, so it's not necessarily the chemical makeup of the particle, it's just the physical size of the particle.
Yes. So
right.
The concentration and speed that enters is the predominant trigger for the immune response.
And do you think just
on top of that, it's the composition, but that's secondary.
Got it. Thank you. Yeah. Do you think just a small number of these nanoparticles getting into the circulation could be problematic, or do we need a lot of them to get into the circulation to cause problems?
There's a threshold on the number per time. So a small amount with a large concentration can trigger. A few microliters with a high concentration can trigger. If you dilute it and then inject more, that's not a problem. So you need to stay under the radar of the cascade of the immune system too.
So even if a very small amount gets into the vascular system, that could trigger this immune response.
Yeah, no, I've experienced that with my product development. So
yeah, this is your professional field, isn't it? Yeah. So is the other viruses, the adenovirus vector vaccines, are they particulate in nature as well?
Sorry, I didn't get.
So the adenovirus vector vaccines, they're small particles as well as the messenger RNA vaccines, are they?
Yeah, a bit bigger. They're around 100 nanometer, 120.
Okay, but that's the same size as the virus, exactly the same size as the virus itself.
Yeah, that's the virus size, and therefore also the body responds to it.
Yeah.
On top of that, the adenovirus have receptor or have coating on the outside that actually can bind to blood cells and to platelets. There's a very specific receptor that makes them activate and enter the platelets.
Right. So
that was known already for a long time.
Yeah.
It's nothing there.
So the adenovirus vector vaccines, as well as the physical size that can trigger the immune response, it can be the chemical profile of the molecule that triggers the response as well.
Yeah.
And people have known about this for a long time.
Yeah. No, this is old knowledge published more than 20 years ago and repeatedly. And people know, don't inject these in the bloodstream. That's where you can trigger all these effects. And again, that's always dose and concentration and time dependent. So it's not black and white. It's not, if you get a little bit in, there's a trouble. But if it's more and you're sensitive to it and maybe have other reasons to respond bad, it could end up in this negative cascade.
But this is a known clinical contraindication that you never give microparticulates directly into the bloodstream.
You can do that. Also, a liposome is a drug delivery system on the market for a long time, intravenously, but you always monitor and you have it in a dilution that can work. There's sometimes pre-medication. And you monitor. You really monitor for these side effects. The thing to do is to stop, wait, and continue.
Yes, but with a vaccine, you give a bolus dose and send the patient away, so that doesn't apply.
And you leave them wait now for 15 minutes, I think, in case something has happened.
Yes. So are these current mRNA and adenovirus vector vaccines fundamentally different from previous generations of vaccine?
I think they are. Yes, they are vector vaccines. Both are intended to bring the protein of the coronavirus in expression, where previous versions of all the vaccines either give the protein or give the virus that is inactivated. But now we give it as a vector that we want the body, our own body, to produce it. And that's a fundamental difference in strategy. And they are particles now. And that's also new. We haven't injected so many people either with viral vectors or with lipid nanoparticle vectors. So both are new classes. New. I mean, of course, there have been trials in gene therapy and other indication, but these are limited number of people and well controlled and very well investigated.
So just to be clear, previous vaccines were not microparticulate. These new vaccines are microparticulate.
Yes, well, in that much as if you have a virus that you inactivate, it can still have that microparticle form. Usually they aggregate even more, so it could be micron particles. And they are intended also to stay in the site of injection in the muscle, also not for intravenous. Yes.
I mean, presumably this would be taken into account in the clinical trials that were done for these vaccines, was it?
Well, I don't think they did. No.
No, I can't remember reading it either.
No, and I've looked for it, and the design is the classic vaccine for the regulatory framework. And I've also looked at the follow-up studies that have been asked by the agencies for the pharmaceutical companies to perform, and they're not part of it. And I think that is an omission that should be filled. You want to know, even if it's a small amount, where it ends up, how long it stays there, what it can produce, and how the body can respond to it. Because it's a vector and not something that is just in the arm and disappear. It can have a longer effect life because it's intended to have a longer effect life. And if it then wanders in the body somewhere, and you don't check where it can end up and how long and what it does, I think that these are studies that have to be done. And then we can understand and appreciate side effects. Otherwise, we don't even understand something can happen somewhere in the body. If you don't know it ends up there and can have an effect. All these things should be documented. And that takes time, but that time should be used.
So it's scientifically possible that these microparticulates could be interacting with platelets, potentially getting into the cells of the myocardium, for example.
Yeah, and I think when I started to look at this, that was based on older particles and older vaccine viral particles. But now already all the scientific groups have looked at that kind of effect in animal studies with the actual vaccines. And
yes, it's actually been seen in animal studies. Yeah.
Yeah. First, it was theory based on literature, and very obvious it should and could happen. And now all the actual proper work has been published by scientific groups. And that's good, because now there's more attention and people can refer to good scientific papers.
Yeah.
Now still policy needs to change and take this into account. Because the obvious fix is with the aspiration.
Yeah.
It's one of the first things you can do.
Yeah, so it seems to me that the World Health Organization and the European Medicines Agency and the Green Book in the UK just carried on with the old recommendations for the old-fashioned type, the older type vaccines. Now we've got a completely new type of vaccine, and they haven't changed their advice.
Yeah, I think that's two separate discussions. One is the advice on aspiration, the other is how you should construct your development dossier and your regulatory filing. I think in the regulatory filing there should have done more work on distribution and effect, and effect and interactions in the body. For the injection discussion is they've used the old instructions that aspiration is not needed.
Yeah.
But that concept is based on pediatric vaccinations.
Yes.
Where you prevent endemic viruses or other infections to occur. And then it's not so much of a trouble if you miss one dose in a kid. You still have the group and the herd protection. If you miss 1 or 2 times, 1,000 a kid. But with this virus, we are in an endemic situation.
Yeah.
You don't want anyone to miss a dose.
So
if in the bloodstream and nothing happens on the side effect, it doesn't still work.
Got you. So if you
should control for it, that's you want to.
So if you give it into a blood vessel, not only can you get the side effects, you probably won't get the immunological benefit from the vaccine.
Maybe you do, maybe you don't. That's the problem.
We don't know. Yeah, we don't know. We don't know.
I hope you still get it.
Yeah.
But it's not the intended route and not how it was registered.
Yeah.
Yeah. And maybe it's even better. I don't really.
We don't know. Yeah, that's the point. We simply don't know. Yeah.
It can occur.
Yeah. Peter, I want to leave that there because my mind's just reeling with the import of what you've told me. That's absolutely astounding, and it's good to know that the science is consistent with the research papers that we've been reading and with the thinking that we've been developing over the last while. Let's hope some people will listen to this video. But I can't let you go without looking at that picture behind you. It's absolutely fantastic. Would you like to show it to us?
Yeah, it's beautiful, right? Yes, it's on display in the museum in the city of Leiden, in Boerhaven Museum. It's a historical medical museum. I had it made by Gunther Verhagen, the plastination artist, and it's a real human brain.
Wow.
This is a picture of all the 600 kilometers or 400 miles of capillaries that a human has in the brain. This is my profession. I work on the barriers in the brain, the blood-brain barrier, the blood-retina barrier.
Yeah.
My profession is to make a lipid particle coated with a body-own peptide, an antioxidant peptide, and the brain needs that. So then the whole particle can get better uptake in the brain.
So your whole specialism is how things get from the blood into the tissues. That is your Wow. I think
these kind of lipid particles, the size of the virus.
Yeah. Wonderful, Peter. Thank you very much for coming on. It's absolutely fascinating, and I mean, let's keep abreast of the research and potentially
talk again. And asking agencies. I've been asking our national agencies as well to look at it. And so far, not a lot of response, but I think this kind of videos that you make can help a lot.
I hope so.
Getting people to open up again.
Yeah, it's an important point. Peter and myself are not able to give you specific advice, but we're able to ask questions that are simply not being addressed at the moment, and we want them to be addressed.
Right.
Great. Thank you very much, Pieter. Wonderful. And thank you for giving up your a big chunk of your Saturday for this video.
No
Really
problem.
appreciate it. Thank you.
Love to do it.
Thank you.
Bye-bye.
Bye.